Hello, good morning. Today I am going to present the topic papilledema, which is very important in the department of neurology. Now, what is papilledema? Papilledema is disc edema, and this disc edema is due to rest intracranial pressure. When the disc edema is not due to rest intracranial pressure, then it is not papilledema. Usually, papilledema is bilateral, but very rarely it can be unilateral also. In the department of neurology, the most important part of fundoscopic examinations is to detect the optic disc and optic cup. So what is the optic disc? Optic disc is the most anterior part of the optic nerve. This is the optic disc. This is the most anterior part of the optic nerve, and this is actually the exiting region of the axons of ganglionic cell. Now, what is optic cup? The optic cup is the central part of the optic disc. So this is the central part of the optic disc, and this is the optic cup. Normally there is a ratio of the optic cup and optic disc. Normal cup to disc ratio is 0.3 to 0.5. Here the diameters of the optic disc and optic cup. Now, what are the parts of optic nerve? Optic nerve has four parts. The one is intraocular part, another is intraorbital part, and intracanalicular part, and intracranial part. The intraocular part we can see through fundoscopy, and this is the optic disc, most anterior part of intraocular part. The intraocular part also this is the intraocular part of the optic nerve. It is also called optic nerve head, and this optic nerve head has five parts. The most anterior part is nerve fiber layer. This is nerve fiber layer. I am going to show. This is the nerve fiber layer. Then prelaminar region. Then lamina cribrosa region. Then postlaminar region. Okay. So this is the anatomy of the optic nerve. So this is the optic nerve. This is the optic nerve. This is the optic nerve. This optic nerve begin from the retina and goes toward the brain. This is the optic nerve. Optic nerve. Optic nerve. And in the central of the optic nerve there is a vein. This is central retinal vein. This is also come to the retina. Okay. So around the optic nerve there is a space that contains CSF. So this is CSF containing space, and around this CSF containing space in the outside there is meningeal sheet, meningeal covering. This is meningeal covering. Okay. Now I am going to show you. So why there is papilledema in rest ICP, rest intracranial pressure. So this is normal anatomy of the optic nerve, and this is the pathology explaining why there is papilledema in rest intracranial pressure. Here the CSF pressures is increased, cerebrospinal fluid pressures is increased around the optic nerve, and this pressure compresses the optic nerve, and when the pressure compresses the optic nerve, then here the exoplasmic flow of the optic nerve, the flow of the exoplasm through the axons of the optic nerve is hampered. So there is swelling of optic nerve head. Optic nerve head is swollen here, and when the pressure also transmitted to the central part of the optic nerve, I mean central retinal vein, then the venous flow through the central retinal vein also interrupted. And for this there is also swelling of the vein, and this is venous distension. And as a combination of venous distension and also swelling of the optic nerve head, there is papilledema. Papilledema means the disc edema due to rest intracranial pressure. So how to explain the pathogenesis of papilledema in rest intracranial pressure? One is compression of central retinal vein and another is blockage of exoplasmic transport. So what are the stages? There are 4 stages of papilledema. One is early papilledema, then established papilledema, then chronic papilledema, and last atrophic papilledema. Now the early papilledema. In early papilledema, there is hyperemia of optic disc along with mild elevations of the optic disc, and disc margins. Here is the disc margins is blurred, comparatively blurred. Disc margins blurred. Loss of spontaneous venous pulsation, and there can be also superficial hemorrhage, but there is no hemorrhage. Now established papilledema. In established papilledema, there is angosed vein and tortuosity of the vein. Numerous flame-shaped hemorrhage can also be found. So much cottonwool spot and hard exudate can also be found. And retinal fault with macular signs are the signs of established papilledema. Now chronic papilledema. So in chronic papilledema, the previous hemorrhage exudate all are absent, all are reduced, previous hemorrhage and exudate, but the disc color is pale, and optociliary shunt vessels are present. Here is the optociliary shunt vessels. So this is atrophic papilledema. So in atrophic papilledema, the color of the optic disc become pale. This is pale in color, and also vessel numbers are reduced and retina shows pigmentary changes. So in the previous slide, mm, that means in the chronic papilledema, I explained there might be optociliary shunt vessels. What are the optociliary shunt vessels? Optociliary shunt vessels are actually collaterals. Those are the optociliary shunt vessel, and those are the collaterals. And these collaterals are formed between the retinal vessel and also choroidal vessels. Here the central retinal vein is compressed due to rest intracranial pressure, due to rest CSF pressure. So the blood cannot pass through this vein. So collaterals are enlarged and there is shunt. This is optociliary shunt vessels. So we can see optociliary shunt vessels. Those are the vessels with optociliary shunt and optociliary shunt vessels. Now how to classify the causes of rest intracranial pressure? It can be classified in several ways. One of the classification systems is primary and secondary. The primary rest intracranial pressures, also called pseudo-tumor cerebri, and there are so many causes for secondary rest intracranial pressure like tumor, trauma, hemorrhage, venous thrombosis, infection,